Okay, so today I'll be talking about viral sepsis. So this talk I gave in Mysore South Zone conference in 2018 in September. So I think I need to have a disclaimer. I think viral sepsis is a very broad topic. So whatever I'm going to talk is just an overview on the basic tenets of viral sepsis and some newer insights into pathophysiology because we can't really cover each and every virus in 20 minutes talk and some overview on the newer developments that are happening in therapeutic modalities of viral infections. So that would be my disclaimer. So the topics I would be covering is just a brief overview on the virus classification, so modes of transmission, so viral diagnostic methods, and I think this is something where a lot of work is happening about newer insights into pathophysiology because understanding the latest pathophysiological aspects, I think, has yielded into certain therapeutic interventions. So, and these are newer interventions that have been evolved is SLIP2N protein and fibrin-derived peptide in dengue infections. So these are some of the newer modalities which are in the experimental level, and we'll just look into difference between bacterial and viral infections. And since India we have problem with dengue, we'll cover a bit about dengue fever. And Hanta also is very much prevalent in India, so we need to have index of suspicion of for Hanta virus and little bit on human herpes virus and take home message. So the definition of viral sepsis, like bacterial sepsis, is very similar. It is dysregulated host response to a viral infection. So the definition of sepsis is dysregulated host response to a bacterial infection. So same definition holds good even for viral sepsis. So when you look at classification of viruses, so you have DNA viruses and RNA viruses. So there is a Baltimore classification for viruses. So where again they subdivide into double-stranded DNA with reverse transcriptase enzyme and single-stranded DNA, and double-stranded RNA and single-stranded RNA. So this is the classification of viruses. For single-stranded RNA, it is further subdivided into viruses with positive polarity and viruses with negative polarity, and single-stranded RNA with reverse transcriptase enzyme. So this is in rough the overview about classification of viruses. So if you look at the tabular format, I think you would see the classification of these viruses. So the ones that I marked in the red boxes are what is relevant. So hepatitis B virus is something we see commonly. I think filovirida is viruses we see commonly, which involves Ebola virus. So Bunya virida is hantavirus. Flavivirida is the dengue and retroviruses. So these are the viruses which probably are relevant to the clinical sort of outbreaks that we see worldwide. So the methods of transmission, so I just put it in a pictorial format. So if you look at the viruses which are spread in a inhalational, so they constitute Epstein-Barr virus, hantavirus, influenza, and measles. So these are spread through respiratory secretions or through nasally. And there are viruses which spread through ingestion. So these are Coxsackie virus, enterovirus, rotavirus, hepatitis A, E, Norvac, and poliovirus. So these are the viruses which spread with ingestion. So the ones which spread through needles are these hepatitis B, hepatitis C virus, and HIV. And there are viruses which spread from the secretions from the skin lesions, like vesicles or pustules. So these are smallpox, chickenpox, and herpes simplex virus. So the incubation period of these is typically 2 to 3 weeks. So the ones which spread through respiratory secretions are very short, 2 to 5 days. So there are certain viruses which spread through sexually transmitted, so which would be hepatitis B, HIV, and cytomegalovirus. So the incubation period is usually a bit longer, so it's up to months. So the mosquito, the vector-borne viruses are mainly dengue and yellow fever, and you have the viruses which spread through the bite of these ticks, which is Crimean Congo hemorrhagic fever. So this is in brief the overview of all the different viruses which spread through different routes. So, what are the available diagnostic methods for viral infections? So, the cell culture is one of them, and antigen detection is a more important one to identify the viral infections, which include fluorescent antibody staining, immunoperoxidase antibody staining, and enzyme immunoassay. Then the other way to identify the virus is by nucleic acid detection, by polymerase chain reaction, or other nucleic acid amplification methods. So the direct way of identifying viral infection is by electron microscopy, cytology, and histology. In histology, you have immunohistochemistry and in situ hybridization. But the most practically useful methods of identifying viral infections is serology, and you have something called cytopathic effect. Cytopathic effect is looking at the inclusions within the cells and identifying them by complement fixation, heme adsorption, or heme agglutination immunoassay, radioimmunoassay, and ELISA. So cytopathic effect and serology seems to be the commoner tools to identify viral sepsis, and all the other means that you just heard or something which also could be used maybe in more advanced centers. So if you look at the pathophysiology, so I think the key differences in bacterial and viral you would see. So the bacterial infection, so this is pathogen associated molecular proteins, so which activates the macrophages and causes release of tumor necrosis factor alpha, which leads to leakage from the vessels by causing increased permeability of the endothelial cells, which leads to vasodilatation, vascular leakage, and shock. Okay, so then there is this damage associated molecular proteins. So that also causes activation of macrophages and leads to production of tumor necrosis factor alpha and interleukin 1 beta, which causes adhesion of these. Basically, it makes all the leukocytes sticky, and these leukocytes adhere to the endothelial cells and leads to worsening of the inflammation. And there are these other mediators which get released from these macrophages, which leads to production of the fever and which can cause release of acute phase protein from the liver. So this is in roughly the pathophysiological mechanisms, overview of the pathophysiology that happens in any infection. But there are some distinct differences between bacterial and viral infections. So if you look at bacterial infection, the mediators of inflammation is predominantly interleukin 1 beta, which causes interleukin 6, and that leads to production of CRP. So this is the pathway of bacterial infection. So CRP rise in an infection is more representative of bacterial infection. But if you look at viral infection, the mediators of inflammation is through interleukin 18, which predominantly produces ferritin. So what I am wish to reiterate here is in viral infections, ferritin seems to be a surrogate marker of possible viral mode of infection, because for in bacterial infection you don't see much of a ferritin rise, rather you would see CRP rise. But in viral you will see more of ferritin rise. I think that is one marker which one could use to look at as a surrogate for viral sepsis. So this is an most recent article when I delivered this talk, which I went through. I think this is the most updated article looking at all the pathophysiological elements and the newer modalities that are being developed in viral sepsis. This came from the Canadian group. So what this article emphasizes is the predominant pathognomonic feature in viral sepsis is this aspect. You will see mainly the cellular leakage. It is paracellular leakage and transcellular leakage. So there is leakage of fluids that is happening in between the endothelial cells within the vasculature, and there is leakage of water content even from the cells. And this remains the main pathognomonic feature of viral sepsis. And why does that happen? I think there has been a lot of studies that have happened. So they have identified there are three elements within the vessels which maintain the vascular integrity. So what are those three elements? So one is adherens junction. So this adherens junction is constituted by what they have. See, if you look at this is a dumbbell shaped proteins. So what they have called as vascular endothelial cathedrin. So that's the name of this, and the function of this is mediated by the calcium. So this is the one which maintains the integrity of the endothelial integrity within the vascular within the blood vessels, and this integrity is maintained by the calcium. And glycocalyx is another one which maintains the endothelial integrity. And there are these tight junctions. So these are the three main elements which maintain the vascular endothelial integrity. Okay. And as I said, this adherence junction is mainly maintained. The integrity of this is maintained by vascular endothelial cathedrin, and which is dependent on calcium to remain stable. And in addition to this, this adherence junctions binds to these cytoskeleton. So there is cytoskeleton within the endothelial cells which keeps it firm and stable. And these adherence junctions bind to this cytoskeleton actin through some of these proteins called P120. And so is tight junctions, which are bound to this actin by a protein. So this is the main sort of the characteristics of maintaining vascular integrity. And when they get disrupted by the viral infection, that's when the vascular leakage happens, and we'll see how that happens. So when there is a viral infection, so what really happens is there is, see, if you see this, there is a breakdown of vascular endothelial cathedrin, which is mediated by signaling of this particular thing, vascular endothelial growth factor receptor. So because of the signaling, abnormal signaling from this, so there is a breakdown of vascular endothelial cathedrin, and there is an endocytosis that happens. So basically there is a breaking down, and there is a reabsorption of this by endocytosis, and that's when the whole integrity of the vascular endothelium is lost, and there is a paracellular and transcellular leakage that sets in. Then the another way is they have shown that this sphingosine 1 phosphate causes activation of certain proteins here, and that also leads to breakage of the integrity. So looking into these elements, so they have tried to identify this protein at an experimental level called SLIT2N protein. And this SLIT2N protein is shown to stabilize this integrity of vascular endothelial cathedrin, and that has shown to reduce the transcellular and paracellular leakage. So the reason why this is important is, I think the whole discussion revolves around this dumbbell-shaped vascular endothelial cathedrin, whose integrity, if it is lost, that leads to all the pathognomonic findings in sepsis. And to that effect, they've identified this protein called SLIT2N, which is shown to stabilize this particular vascular endothelial cathedrin. And even it has shown in an animal experiments to have survival benefit, and it's possible potential new avenues in treating viral sepsis. Okay. So, and this was an animal study where they have given this injection SLIT2N, and they have shown in the lungs as to what happens to edema, inflammation. And as you see, this is pre-injection and this is post-injection. So edema and inflammation has significantly come down. So and we need to understand that in viral sepsis, as in bacterial sepsis, there are two different phases that exist. So one is the pro-inflammatory phase, where there is a whole activation of all the immune mediators, and once this pro-inflammatory response abates, then they go into something called anti-inflammatory response. That is where you see more of immune suppression, what we call as compensated anti-inflammatory response syndrome. And it is found that it is in this phase there may be viral reactivation that tends to happen, and which may lead to death. So this is also something we need to keep in mind, because in any sepsis there is this immune suppression that sets in. That is where the dormant viruses tend to get activated, which leads to other deleterious effects. So let us look one by one as to what are the key differences between bacterial and viral infections. So some of the key differences is, if you look at the total count, we all understand in bacterial infections total counts go up, but in viral it can be normal or it tends to be lower. So that is something we need to know. And if you look at prodrome is more typical of viral. Like if you have a flu or influenza or dengue, I think they tend to have more severe prodrome than bacterial. Bacterial just manifests with whatever fever and other clinical symptoms and signs. And acute MODS. See, bacterial infection to cause multi-organ, it takes little time, because it Generally you would agree that when a bacterial infection happens, the organ dysfunction tends to happen in a sequential way. Maybe if you have, say, um, severe community acquired pneumonia or severe UTI, maybe you will first have acute kidney injury, or you may have tachycardia, then followed by some hypotension. But viral multi-organ dysfunction tends to happen all at once. So when a patient typically comes with viral with MODS, you will see like typical dengue when they come. He may come with low platelets, he may come with hypotension, he may come with raised liver enzymes, he may come with altered sensorium all at once. So the acute MODS, I'm using the word acute. So acutely having multi-organ dysfunction is more likely and more severe with viral infection. And serositis is typically, we understand, is more common in virus, because in dengue you see it is predominantly marked by a lot of serositis with a lot of effusions in pleural cavity and in the peritoneal cavity. And as I already mentioned, CRP and procalcitonin seems to be more in bacterial sepsis than in viral, because in viral what we see is more of ferritin. So I think this is something you can utilize in your clinical practice as well. And lipopolysaccharide binding protein tends to be more in bacterial sepsis, and neutrophil lipocalin is also more in bacterial and not seen in viral. So these are some of the key differences between bacterial and viral. So if you look at the cytokine levels, so even cytokine levels, there are differences between bacteria and viral. So I have marked the key differences in red. So if you look at interleukin 1 or alpha, that is increased in bacterial, but it is normal in viral. If you look at interleukin 6, it is increased in bacterial and it is low or normal in viral infection. So let's look into the classification of viral hemorrhagic fever from clinical parlance. So if you look at major viral hemorrhagic fever, so it is mainly classified into two major ones: arbovirus and non-arbovirus. So in arbovirus you have flavivirus, bunyavirus and reovirus, and in non-arbovirus you have bat virus and rodent viruses. So in under this you have mosquito borne, which is under flavivirus, which is yellow fever and dengue fever. And under this bunya and flavi you have mosquito borne Rift Valley fever. Then here you have tick-borne, which is Congo Crimean hemorrhagic fever. Tick-borne you have Colorado and tick virus. Bat virus you have filovirus, which is Ebola and Marburg. So rodent virus you have Bunya virus, which is Hanta virus, Arena virus, which is Lassa fever, and South American hemorrhagic fever. So this is in brief the classification of viral hemorrhagic fever. Okay, and what is relevant to us is possibly the dengue virus, which is comes under flavivirus. I think Ebola made some news, and Hanta virus is claimed to be present in India. So Congo Crimean hemorrhagic fever probably is more in African countries. So now let's look into dengue, because this is what we deal in India. I think we need to know a little bit about dengue. So this is flavivirida. So at risk population is around 2.5 billion worldwide. So that is the burden of dengue virus. Annual incidence is 50 million. So we need to understand how dengue virus causes all the pathognomonic features, and this is the latest. So if you look at dengue virus, it is known to produce tumor necrosis factor alpha, and that is implicated to cause directly the vascular leakage. In addition to that, it causes reduction of activated protein C, and that also leads to lot of paracellular or transcellular leakage. And in dengue fever, they found there is something called dendritic cells, which produces, where there is increased production of gelatinolytic metalloproteinases. So gelatinolytic matrix metalloproteinases, which is shown to again affect your vascular endothelial cathedral, which acts as a bridge between the endothelial cells in the vessels. So these are the three main pathognomonic things which causes transcellular and paracellular leakage, which leads to your hematocrit rise and the fluid loss. So dengue, if you have to look into the clinical spectrum, you can divide into mild dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. So what they have done some experiments where the rats were injected with dengue virus to see if there is any new modalities of treating dengue. And after 3 days they gave this protein, that fibrin derived product which I said, FX02. That FX06 was the code name, but it is a fibrin derived peptide. So they gave it twice, and the mechanism of action of this is that it binds to vascular endothelial cathedrin, which stabilizes the junctions between the endothelial cells. And they found in experimental models that it reduced lung and interstitial capillary leak, and it showed to improve survival. So when you look at the clinical phases of dengue, so if you look at, this is days of illness, day 1 to 3. I think 1 to 3 is the time when temperature increases, and that is when you have a phase of dehydration, and hematocrit tends to come down, and viremia is maximum in 1 to 3 days. 4 to 6 days is where all havoc happens, where temperature comes to almost baseline. So generally you would agree, any patient coming to ICU with multi-organ or in a severe stage, seldom do they have temperature. So temperature comes to baseline, but that is when they are in shock, and that is when they may be bleeding. And that is when you see the hematocrit rising and all the lab abnormalities. And viremia is usually would be down at that phase, because the viremia is maximum in the first 3 days. And after 6 days, dependent on how effectively he is treated, so there is a reabsorption of the fluid, or there can be fluid overload, and platelets can tend to increase, and your IgM and IgG tends to get detected a lot more effectively in this time frame. So these are the typical phases of dengue fever. So the dengue incubation period is 5 to 7 days. So this is the grading of the dengue, which is sort of universally, I think this come from WHO. So you have grade 1 dengue hemorrhagic fever, where duration of fever is more than 2 days and less than 7 days, and where you have positive tourniquet test, and your platelet counts are less than 100,000, and there is plasma leakage. Grade 2 is your fever more than 2 days but less than 7 days, but grade 2 is where they have spontaneous bleeding that has set in, and platelet is less than 100,000, and they have plasma leakage. So it is the increasing severity. Grade 1 is mild, second is moderate. Grade 3 is dengue shock syndrome, where you have duration of fever more than 2 days and less than 7 days. They have positive tourniquet, but the problem is they can have spontaneous bleeding. Platelet is less than 100,000, but what you typically see is hypertension. So this is a dangerous phase you want to see anyone, or they can have circulatory failure. And phase 4 is dengue shock syndrome again, where duration of fever is more than 2 days, positive tourniquet test, platelets less than 100,000. But stage 4 is literally perimortem, where they have undetectable pulse and blood pressure. You really do not wish to see any patient in these two phases. So how do we approach treatment of dengue? So this is also derived from, there is a good WHO guideline which elucidates how to approach a case of dengue. So if you have a compensated shock, which means systolic pressure is maintained, plus signs of reduced perfusion, you start isotonic crystalloid fluids at 5 to 10 ml per kg. So these are all where you are seeing there is no shock. So it's a mild dengue, you start at 5 to 10 ml per kg per hour. So if there is improvement in the fluid status, then you would reduce the crystalloids to 5 to 7 ml per kg per hour for 1 to 2 hours, followed by 3 to 5 ml per kg. So basically you wean the fluid resuscitation to 2 to 3 ml per kg for next 2 to 4 hours. And as the clinical improvement is noted, so you would start reducing the fluids, and you may give bolus if there is any if there is any intermittent worsening of the hydration status, and you could stop IV fluids at 48 hours. But if you start with this 5 to 10 ml per kg and there is no improvement in the fluid status, then what you do, you check hematocrit, and if hematocrit is high, you increase from 5 to 10 to 20 ml per kg per hour for 1 hour, and again assess if there is improvement. If there is no improvement, again you check hematocrit, and then you may have to further increase your crystalloid boluses. But if there is improvement, again you reduce IV crystalloids and go to this protocol. So again you go to 5 to 7 ml per kg and slowly wean it to 2 to 3 ml per kg per hour. So I think the phase we see in ICU is typically this. We check hematocrit, we give crystalloids at 10 to 20 ml per kg per hour, we recheck, and we repeat these boluses, or maybe we may sometimes have to increase these boluses. So if there is no improvement, if you check hematocrit and there is severe overt bleed, then you may have to give blood transfusion. If there is no bleed, then the suggestion is you could consider colloid in this situation at 10 to 20 ml per kg per hour. So in ICU, typically we get to deal with these two scenarios. So this is a WHO recommended algorithm for dengue fever. So let's move to hantavirus. So we saw hantavirus comes under Bunya virus. So it's a hemorrhagic fever. So hantavirus presents as two entities. It presents as hemorrhagic fever renal syndrome or hantapulmonary syndrome. So these are the two. So it can affect lungs or kidneys. So basically, the mode of transmission is through inhalation of the infected rat feces. So it can present with pneumonia, effusion, pulmonary hemorrhage, or severe rhabdomyolysis, severe muscle aches. And but the good thing is there is treatment for hantavirus, which is ribavirin. Okay. So let us understand how does hantavirus produce all this pathognomonic. The reason I'm showing these slides is what we have understood at least from this review article in 2017 is the main pathognomonic or pathophysiological problem we see is with this vascular endothelial cathedrin and paracellular and para intracellular leakage. So here also, even if you look at the hantavirus, so what they found is you have something called integrins from the endothelial cells. So this integrin is meant to work in tandem with vascular endothelial growth factor receptors. So this hantavirus binds to this integrin, and it binds to this integrin, and again here it causes endocytosis of vascular endothelial cathedrin. See, vascular endothelial cathedrin is meant to be like this, acting as bridge between the endothelial cells. So it binds to this and it pushes back into the cell, leading to endocytosis, and basically it leaves gaps causing vascular, paracellular or intracellular leakage. And in addition to this, by binding to these integrins, so it makes these viruses bind to the platelets. So there is lot of platelet consumption that is happening in the within the blood vessels, leading to thrombocytopenia and hemorrhagic manifestations. So this is the key pathological features. As you see, even with the overall virus, vascular endothelial cathedrin seems to be the problem. Even with individual viruses, there is some role in which it causes disruption of this vascular endothelial cathedrin. So let us look at the human herpes virus. So human herpes virus, even if you look at the pathophysiology, again here this causes phosphorylation of vascular endothelial growth factor, and that leads to activation of all these proteins, RAC, GPR and all this. And again here you see it causes endocytosis of this vascular endothelial cathedrin, and there is vascular leakage, paracellular. So let us very briefly look into the herpes simplex virus 1. Is it important to intensive care? Because it is shown that it can cause VAP in up to 5 to 64% of the patients, and the median incidence or occurrence is 15 to 20%. And the activation of this herpes simplex virus can happen in 3 to 5 days of ICU admission, and it can manifest at day 12 with all the problems. So the risk factors for herpes simplex virus 1 ventilator associated pneumonia is any patient who is on long-term steroids, or if you have a very sick patients, or any patient in ICU with herpes labialis or long-term ventilation. So these constitute the risk factors where it can cause activation of dormant herpes simplex virus 1, which can eventually lead to ventilator associated pneumonia. And as you see, the occurrence rate is not very small, so it seems to be common. So we need to have high index of suspicion in trying to determine that if our patients have herpes simplex virus 1 pneumonia. And the risk factors are steroids, and if you see any patient with herpes labialis developing worsening gas exchange, maybe you should consider that he may be developing herpes simplex virus pneumonia. So the take home message, viral sepsis is common cause of ICU admission. So I think the decision making in viral sepsis is sometimes difficult because of non-availability of appropriate lab tests apart from the standard viruses like dengue, we do not have robust lab tests for other viruses. Because of this, I think our ability to prevent and diagnose viral sepsis early can be a problem. And there are limited treatment options. Even if we find out that patient has dengue virus, or if they have other viruses like ebola, our treatment options are very limited. So for hantavirus we have ribavirin, and for herpes we use acyclovir. But for most other viruses we do not have specific therapies like antiviral agents or vaccines, so that limits our therapy in viral sepsis. But the whole purpose of this talk is to highlight the importance of understanding the pathophysiology, because by understanding the recent advances in pathophysiology and identifying these two new proteins like SLIC2N protein or fibrin derived peptide in dengue, I think that may pave our pathway for effective treatment options. And like bacterial infections, viral infections spread from one patient to another, or it will put healthcare professionals under risk. So, stringent infection control measures and isolation measures to contain spread of viral sepsis is very important. If you have a viral outbreak or viral sepsis patients, like herpes in particular, I think they need to be, or Nipah virus, or Crimean Congo hemorrhagic, or Hanta. So sometimes it may be mandatory that they are kept in isolation and treated. So thank you very much. So I would end my talk with this quote from Sadhguru. So it's the ability to bring out the best in others that make you a leader. Thank you very much.